Hi. About 26 or 27 years ago, I started New England Hand Associates just as me, being the first, what I like to call, real hand surgeon in the Metro West area, also at Emerson Hospital, and then gradually out here at Milford. At that time, it was Milford Hospital. By hand surgeon, I mean all three of us have trained in orthopedic surgery, then did a fellowship in hand or hand and microsurgery, and practiced full-time upper extremity and hand surgery. All three of us have board certified through the exam in surgery of the hand and members of the American Society for Surgery of the Hand. So we go to three different hospitals, but it's very, I think I can speak for my partners when I say Milford Regional is our favorite place. And I actually say that at the other two places too. So, and the growth I've seen in this hospital over the last 25 years has been fantastic, as you all know, in this community. It's just become a truly high-quality, caring institution that is just a pleasure to come here and see people and work with the physicians here, and that's why we're here. So I'm going to start and talk about several hand and wrist problems. I'm going to try and keep it to the most common problems that people have, and then we're going to march up the extremity. Dr. Dietz will talk about the elbow, and Dr. Brunelli the shoulder, and then we'll have plenty of time for questions and answers afterwards. Okay, I do like to, you know, the title of the talk was Hand, Wrist, Elbow, Shoulder Issues, Get Armed with the Facts. Very nice pun there. So I will add one to that before we start, and that's that as hand surgeons, we're the only doctors where we ask our patients to give us the finger. Sorry, thought I'd try that. So I'm going to talk about several common hand problems that we see now that have been common for a long time, and there's some new ways we treat some of them. I hope you did get to read the article in the Good Feelings magazine. That's probably why you're here. I think it's very well written and gives a good taste for the kind of things we do and how we feel so positively and warmly about this institution. So everyone's heard of carpal tunnel syndrome, and we often get patients who come in who think that anything that hurts their arm from the elbow down is carpal tunnel syndrome, but it's not, but we'll get into that. This cartoon shows the turkey before Thanksgiving saying, "What if I told you that repetitive motion tasks can lead to debilitating carpal tunnel syndrome?" hoping the hatchet will not drop, and of course that doesn't work. But if you look at the numbers at the bottom, you see the magnitude of this problem, and that's why we're talking about it first. 4 million new patient visits a year nationwide for this problem. It's unbelievable when I saw that number. 600,000 carpal tunnel release procedures per year, and the three of us aren't doing all of those. So it's very, very common. I've had both of mine done a few years ago. Mike had one done. We got to work on the other. And it's and we'll talk about how that has evolved over the years. So first, what is it? It actually is an actual tunnel at the wrist. The tunnel, the bones of the wrist form the floor of the tunnel. The thick transverse carpal ligament going across forms the roof of it, and through that tunnel run the tendons to the fingers, and then the problem here, which is the nerve called the median nerve, that goes through underneath the ligament through the tunnel and then comes out with the branches going to the thumb, index, long, and part of the ring finger, and to the muscles at the base of the thumb. And that becomes important in terms of what the symptoms are and what causes it. The problem actually is a pinched nerve. That nerve itself gets pinched there, sometimes because there's swelling around the tendons pushing from below, sometimes because there's bony deformity from an injury for the floor, and sometimes the ligament itself is thickened and tight and pushing from above down on it. So what you feel with that when you have the nerve being pinched and pressure on it, numbness, tingling, pain in the hand and wrist, paresthesias, or burning, specifically in that nerve distribution. So most of the time with carpal tunnel syndrome, you're not going to feel anything in the little finger. You're not going to feel anything abnormal in the little finger because that's a different nerve. The worst part of the symptoms are the waking up multiple, and I can tell you this, waking up multiple times at night. And a patient last year described it to me as painfully numb, and that is a perfect description, that it can be dead numb and at the same time burning and painful, and you just can't wait to make it stop. And a lot of patients say it's circulation because it feels like that, but it's not. It's from the pressure on the nerve. As it gets more advanced and you have numbness, you drop objects, and the dropping objects are trouble with buttons or earrings or small objects is related to the loss of sensation. You can get muscle weakness and atrophy when it gets very advanced. And so that's how we evaluate it when we see someone with carpal tunnel syndrome. The most important part of making the diagnosis is talking to the patient, examining the patient. We look to see, in addition to the history, the symptoms that I just told you about, sensory exam. Where is it numb? Where is the sensation different or abnormal? And usually it'll follow that distribution of some combination of these 3 or 4 fingers. The muscle here at the base of the thumb, when it gets weakened or atrophied, that's very advanced. We don't want it to get that far advanced. You should come see us before it gets that far advanced. These other names, Tinel's, Phelan's, and compression test, are all ways to excite the nerve, make it tingle, and see that it's not a happy nerve, basically. There's pressure on it. Occasionally we'll do a nerve test. Anyone who's had an EMG, has anyone here had an EMG? So it's not the most fun thing. Right. No one ever comes back to our office and says, gee, can I do that again? Sometimes we have to do it because it's not always crystal clear. Not everyone presents with the textbook symptoms for it. And so sometimes we have to do the test. There was a period of time when the insurance companies were making us do it on everybody, and that was really ridiculous and unfair. And I had so many discussions with them to try and say, you're causing needless pain and suffering, let alone the cost of it. And eventually now it's at the stage where I think we have a little more discretion most of the time to obtain the test when we think it'll help with the diagnosis, but when we don't need it, spare you the discomfort. Well, hopefully you don't know what being tasered is like, but it is a shocking test. Let's say that. This is an in-office version of the test that we sometimes do, not as much as we used to, but the idea is it electrically stimulates the nerve above the wrist, measures the conduction across it, and tells us if it's delayed. So then, how do we treat this? And not everyone needs surgery for it, and we'll get to that but in a minute. If someone presents with what I refer to and what is generally thought of as mild carpal tunnel syndrome, that means symptoms for less than 3 months, the nighttime waking up but no numbness, tingling during the day, no dropping objects. Sometimes we'll start with or if someone has a temporary reason for it, like often we will get women who are pregnant referred to us, and because of the hormonal changes and the fluid retention, they get most of the time, once they have their baby and the swelling goes down, it can stop. So we're going to treat it symptomatically because most of the time, but not all the time, they won't necessarily need surgery for it. So a wrist splint at night, because a lot of the reason you get the nighttime symptoms is because we'll sleep like this or we'll sleep like this, and that'll increase the pressure on the nerve and provoke it. So a wrist splint at night can help. Often a steroid injection. And I can tell you that this is one of the least painful steroid injections we give. Some are painful. This one is so minimally uncomfortable that I was able to inject my own carpal tunnels. And I'm a wimp. I don't like needles. But it really can help tremendously. 80% of the time it'll improve, but often it's temporary. So it is useful symptomatically, and also it's useful diagnostically in that if we're not sure whether or not you have carpal tunnel syndrome, the exams may be equivocal, the nerve test may be a little equivocal, the injection can really help because a good response to the injection, even if it's just temporary, really gives us a good feeling that this is what you have and that we can help you with this. And that's where I said if it's atypical symptoms or exam, normal nerve test, don't respond to the cortisone injection, we have to really start thinking about something else causing the symptoms besides carpal tunnel syndrome. And that's part of where the experience and training we have and practice over the years really gives us a better feel for it, because we don't want to do an operation unless we're pretty darn confident it's going to help you. And so what happens is when we do treat this, the more mild cases, in general, across the board, when you have the carpal tunnel surgery, the nighttime symptoms, which are the worst and most bothersome, stop right away. And that's a great feeling. That is a great feeling. If it's a little more involved, you might have some residual numbness that can last for a few months when it's really severe, and the muscle has atrophied. The muscle usually doesn't come back, but even in those cases, and this is something that is sometimes we need to emphasize to patients and to referring physicians, that even if someone is really far advanced carpal tunnel syndrome and we do the release, they're usually going to be happy because those nighttime symptoms stop. They may get some but not all of their sensation back. The muscle may not come back, but overall it's very worthwhile to get rid of a good portion of those symptoms. There are different ways to do the surgery. I'm going to show you a little bit about that. Not too much blood in the slides, but show you a little bit of it. The standard open technique is something that used to be done back when I was a resident in the dark ages of medicine, where it would involve, say, an incision through the whole palm and into the distal forearm, and you go and clean out all the tissue around the tendons, immobilize it for a longer period of time. Significant pain afterwards, significant difficulty getting the motion back, significant short-term disability. Still good relief of symptoms, and in some cases, in some types of problems, we still do it that way if someone has severe rheumatoid arthritis or something like that. The endoscopic procedure is something you've heard about. We all do arthroscopic surgery, which means we use the scope in the different joints in the wrist, elbow, shoulder, and we'll talk about that, and that was in the article as well, as a minimally invasive way to do surgery. It just doesn't work well for the carpal tunnel, at least in our eyes. And it was an interesting study that is now a little while ago, studied rate of complications for carpal tunnel surgery based on a registry in the state of New York. What they showed is something that I've seen in practice and also seen in years of reviewing cases for the malpractice insurance company and lawyers, is that the endoscopic way has approximately 3 times the risk of a nerve injury, which is, you don't want that to happen. That's the whole point of the way we do the surgery, is to protect the nerve and relieve the pressure on the nerve, not to damage the nerve. And also was a very interesting side information that surgeons who do less than 26, and I'm not sure how they came up with that number, but I thought it was pretty interesting, who do less than 26 cases per year have 4 times the risk of a significant complication doing the surgery. And that kind of makes sense, that the more you do, unless there's something wrong with you, the more you do, the better you're going to get at it. And just as an example to compare, I probably do 150 to 200 a year, and Dr. Brunelli and Dietz probably similar ballpark numbers if we actually look at it. So that adds up to a lot, and a lot of experience, and it just gets you more comfortable with the anatomy, gets you more comfortable with variations in the anatomy that some people have. So this is going to show you briefly what we do for a limited incision carpal tunnel release, the way we do it. It's about a 2 centimeter or 3/4 of an inch incision in the palm, usually in the skin crease. So you can see here the old surgery would have been to come all the way up like that. So when people talk about, for example, how endoscopic surgery is better than open, they're comparing it to the old way. We don't do it that way anymore. The way we do it now, it's much different. So this is the instrument set that I use, and I think, Jeff, you do too. And Mike has variations of it that work the same way. And the idea is to separate, the ligament is going across here, and we're trying to make it, release it, so that essentially what happens, if you think of it this way, is there's a tunnel like this. We make a slit in the top and it opens up and creates more room for the nerve. And then it fills in, but it fills in and heals bigger, more volume, more room for the nerve and pressure off the nerve. And so that's what we're trying to accomplish here. So first we go in and instrument goes below the ligament. This goes above and below. This creates, the instrument creates the path. And then the bottom one, it's a little hard to tell on the pictures, but there's a vertical knife blade going between these 2 runners. So this will follow the path that's created, and the vertical blade cuts the ligament as you go, while the bottom skid pushes the nerve out of the way to keep it safe and protected. And it's worked out very, very well that way. Here you can see where we're working on that. It's a little hard to see, but the next one now you can see it's the magnification. The nerve is here, and it's indented. You can kind of get an idea from the shadows and the lighting where the ligament going across has been released, and you can see the nerve release there. Stitch it up and go. The whole thing takes about 15 minutes to do as an outpatient, just making your arm numb, as much or as little sedation as people need. This shows a patient who's had both done, and you can see this was the more recent. This was maybe a couple of months earlier, and that's the way it ends up. It's pretty darn hard to find the scar, and heals up pretty well. They're moving the fingers and using the hand immediately. We try and say nothing too heavy or strenuous for a few weeks. for each of the times I had mine, I was back performing surgery the next week. I didn't tell the patients I had had surgery the week before, but it worked out okay. 3 days for you? Well, you're tougher than I am. Just as an example of the difference, though, I mentioned that to say, if any of you are golfers, you may have heard of the late great golf Hall of Famer Ken Venturi, who shortly after he won the U.S. Open in 1964 at Congressional, flew up to the Mayo Clinic to have his carpal tunnel release done. And the way they did it back then was the way I was telling you, extensive incision, cast afterwards. He had to retire from golf shortly thereafter because he just was never the same, which is too bad for golf and too bad for him. But it just shows you how different it is now, where I was back doing surgery the next week. Patients are back to work very quickly, back golfing 3 or 4 weeks. Can't guarantee it improves the game, but you can get back and play. I desperately needed the game to be improved, and it didn't work. But that's the difference now in the way this minimally invasive surgery works for carpal tunnel syndrome, and I think it's a big advance. And anyone who's had it done recently, especially anyone who's had it done recently by any of us, would probably say, why did I wait so long? It feels great. See a few heads nodding in agreement who clearly have been there. I'm going to talk a little bit about arthritis very quickly because I want to move on. And the thumb, I'm just going to show you some pictures of the other two, but the thumb basal joint arthritis is the most common site of arthritis in the hand. And we'll get to that point about arthritis surgery. Dr. Nailbuff, it's a great name for a hand surgeon, Dr. Nailbuff, who was my mentor at the New England Baptist Hospital. He used to hate it when people would come in and snicker about his name, but he was great. And the first quote is an emphasis that it's not what you put in or what you take out, it's the surgeon and the technique that counts. And that's part of what all three of us really like about hand surgery, is that technique matters. And being good at what you do is a big difference in the result from not. And the bottom point that he made in terms of rheumatoid arthritis surgery is you can't always aim for perfect. For something, his point is, for someone who has nothing, a little bit means a lot. So I'm going to talk about thumb arthritis surgery, since it's the most common site of arthritis in the hand. You often have a bump at the base of the thumb, pain with pinching, pain with opening a jar, turning a key, turning a door, and it's fortunately for me, but unfortunately for half the population, 12 times as common in women as in men. And it usually hits what I like to say are younger women in their 40s and 50s. It's definitely getting more and more true. So often when someone will come in, initially we're going to treat them, almost always we're going to treat them conservatively and non-operatively initially. A specific custom-made splint can be very helpful. Anti-inflammatory medication, cortisone injection can often provide significant relief, and it can often last for a good period of time, as you see, 40% relief at 2 years in this study. Only about 20% of the patients need surgery, but the good news is this is about the most reliable, high patient satisfaction procedures we do. And the surgery we do, I'll show you in a minute. This is a diagram showing the surgery we do. There's a bone in here, and the arthritis normally, I don't know if you can see over there, is between the bone and the base of this thumb. This is the thumb right here. What we do is we take out the bone. In the old days, they used to put in implants of titanium or silastica. They found there were problems associated with that. And the best thing is to use your own tissue. In this case, we use a tendon because it doesn't wear out, doesn't have to be replaced, and doesn't have to be revised. And so we take out the bone, use the tendon that's there, that's attached at the base of the index finger bone through a hole to tighten it, fill the space. Essentially, it's about an hour procedure done as an outpatient again. Cast for a month, splint for a month, full-time, splint for a month, part-time. And the vast majority of patients at 3 months, we say, get out of here. And again, the usual comments are, why did I wait so long, and when can you do the other side? So it's a very good procedure. This shows a little bit of what's involved. You can see the picture here is where the bone is taken out. This is the tendon on the bottom, the hole in the bone that this is going to be released in the form and pulled through and pulled back and tied to itself. And then an x-ray afterwards showing the space that's maintained where the bone was. I think because of time, I'm just going to say that the joints in the middle of the finger, the PIP joints, we can do a joint replacement on. And this gets rid of the arthritic joint and puts in a little spacer. And this is part of where the soft tissue reconstruction around it is very big for maintaining the motion. This shows afterwards. You can see it was done on the long finger. The extension and flexion maintains very good motion and gets rid of the pain. Fortunately, for all of us, rheumatoid arthritis, hand deformities like this are something of the past at this point for most patients because of the medicines, the newer medicines that really prevent these deformities from occurring. But just to go through and show this poor woman pre-op and then post-op to show that even in that, this is where he was saying, it's not perfect, but when you have a hand like that, getting to a hand like this is just such a big plus. And I think that there's more to talk. I'm going to stop here because we have two other people to speak, but we can talk afterwards. So thanks. The next speaker, Dr. Jeffrey Dietz, who joined us about 7 to 8 years ago. And fortunately, with his joining us, that enabled us to have the manpower to be able to have a full-time presence here at Milford for the three of us, cover the emergency room 24/7, 365, and be available and be in a full-time office 4 days a week right up the street. And so that's been a big plus to have Jeff join us and to have a big plus for us to be able to provide the kind of care here that we are happy to. Thanks.
So the way I chose to break this talk into was by tissue. And we're going to talk about problems with the tendon, the nerve, and the bone. And because I know everybody's elbows are just killing them, I'm not going to make you wait. We're going to talk about the tendinitis first. Tendinitis is by far and away the most common, tendinitis of the elbow is by far and away the most common problem we see of the elbow in our office. It is called epicondylitis is another name for it. Another name that you probably all know it by is tennis elbow. It's kind of an unfortunate name. Most people that play tennis don't actually get tennis elbow, but that's the way that most people know it. It comes from a irritation of a common set of muscles that insert on the outside of the elbow. That's tennis elbow. You can also get it on the inside of your elbow, and that's from, again, a common set of muscles that inserts on the inside of your elbow. That's called golfer's elbow. We're going to talk mostly about tennis elbow because that's by far and away the most common problem that we see. We don't really know what causes it, but most likely it's related to overuse and micro tears of, is this a pointer too, by the way? Anyone? Is it a, guess not. Mostly it's a overuse and micro tears of this muscle here, the extensor carpi radialis brevis muscle, and an inappropriate healing response that occurs from that. Tennis elbow presents as pain and burning with extension of the elbow. Its diagnosis is typically made clinically, but it can be confirmed with an MRI. We typically do not order an MRI unless we're looking for something else. Most treatment involves non-operative treatment for tennis elbow, and that includes physical therapy, cortisone injections, and braces. And people commonly ask me, well, do they work? So let's talk about what we know about that. Physical therapy. What we know about physical therapy is it's very effective, but what we know is that its benefit is really short term. There was a very famous article that was just published in the Journal of American Medical Association that looked at a long study of patients with tennis elbow. And what they found about physical therapy is those patients did well. When they looked at them, they did great. The patients that had physical therapy did great at 4 weeks. But when then they went and asked them again the same questions at a year, the benefit was really about the same. So most patients were basically about the same at about a year. However, this wasn't statistically significant, but the patients that had physical therapy took less pain medication and had less incidence of recurrence of their problem. What about, that's actually a picture of Dr. Brunelli at his football days when he was all roided out. Now it's a little bit more marshmallow, but just kidding. So steroid injections. What we know about the same article, same group of patients, half the patients got a steroid injection and half did not. When they looked at those patients at a year, 83% of the patients who had a steroid injection said that they were doing great, that they were feeling better. That sounds pretty good, except if you look at the other side of that, 93% of patients who did not have a cortisone injection were doing great as well when asked the exact same question. So really, if you look at it, there were worse outcomes at 1 year with the cortisone injection. That being said, Dr. Brunelli and I were just talking about that. We commonly use cortisone injections as a pain reliever. So what about braces? This brace is an example of a counterforce brace or a tennis elbow strap, which is commonly used by all of us. I think it works in a certain subset of patients, but really the evidence does not suggest that it is more effective than physical therapy or doing nothing at all. So really, what's the bottom line? The literature supports that this problem goes away on its own. The problem is it can take a really long time. It can take upwards of 2 to 3 years. So that's a lot easier thing to say than it is to do, is to tell people it will go away on its own. So commonly, surgery can be effective for this problem. Dr. Brunelli and myself do the same procedure. I believe it's an open debridement of the irritated muscle and to try to stimulate a more healthy healing response. Results are pretty good. 85% of patients regain strength and pain relief at a year. All right, how about tendon injury? Most common injured tendon in the elbow is the biceps tendon. The biceps tendon has a common insertion in the elbow, just distal or down on the radius in the elbow. It's typically caused from a forced elbow flexion against resistance. And the common age population for patients that rupture their biceps tendon is in men in their 30s, although women are very uncommon, although it does occur. Risk factors would be smoking and steroids. The diagnosis is clinically an easy one to make typically. The muscle bulges when it ruptures because of its retraction, and usually there's bruising around the area of the tear. I typically will confirm this with an MRI, and this is a picture of what it typically looks like on an MRI. Non-operative treatment, I think, is a reasonable form of treatment for certain patient populations, for elderly or inactive patients. However, non-operative treatment typically leads to a loss of strength, and it's usually 40% of your elbow flexion strength and 50% in supination, which is what he's doing. The motion that's responsible for turning a screwdriver would be supination, or palm to the sky. So laborers and people that do hard labor with their hands will notice this significantly. So what do we do for those patients? Operative treatment is usually necessary, and that involves a small incision over the front side of the elbow. This is the tendon. A suture gets wrapped around the tendon, and it gets attached to a button. A button is on the end of the tendon here, and it gets pulled through the bone. I think Dr. Brunelli and I both do the same procedure for this. The recovery is really 10 to 12 weeks back to full activity. So let's talk about the nerve. I call the cubital tunnel the ugly cousin of carpal tunnel. It is, unlike Dr. Juris talked to you about the carpal tunnel. Carpal tunnel is a compression of the median nerve. Cubital tunnel is a compression of the ulnar nerve. There are multiple sites in the elbow that can cause the compression. Unlike carpal tunnel syndrome, which causes numbness and tingling and pain on the thumb side of the hand, cubital tunnel, the pinched nerve in your elbow, causes numbness and tingling and pain on the pinky side of your hand. Diagnosis is usually made from history and clinical examination, and this is just a picture of a patient who has, you can see the comparison of the hand on one side to the other with the dimpling and the denting of the muscle on the hand over here is an indicator of muscle strength or muscle strength loss and atrophy, and that's a common clinical exam finding in more severe cubital tunnel. You can also have that fun test, the EMG, that Dr. Juris talked about, although it's commonly negative for cubital tunnel syndrome, so oftentimes the diagnosis is clinical. Non-operative treatment is almost always the treatment, especially for early or mild cubital tunnel syndrome, and it's an avoidance of prolonged periods of elbow flexion. What we know is that cubital tunnel syndrome is worse with the elbow in a flexed position. It puts more pressure on the nerve. So we need to avoid those types of activities. Things like driving a car with the seat too far forward, talking on the phone for too long, and then sleeping. And that's what this is. This is a nighttime extension splint. That will prevent somebody from flexing their elbow at night. This is the $60 version. A little towel and duct tape is the $2 version. So both do the same thing. Operative treatment is sometimes indicated for cubital tunnel syndrome, for severe cubital tunnel syndrome, or for ones that just the conservative treatment does not work. And there are two ways to treat this surgically. One is just to release the nerve. This is a picture of the release. And the other is to release and move the nerve, called a transposition. When you look at them side to side, the studies show there's really not a big difference in outcomes in patients one procedure versus the other, except for patients who have the very severe muscle atrophy that you see in this picture, or symptoms that are persistent and don't go away. The reason why that makes a difference is because the recovery for the simple release is significantly less than the transposition. So that's usually the procedure I favor, again, unless they're in severe cases. How about some gore here? This is some of the trauma that we typically see in the elbow. These are the bones in the elbow. The humerus bone is the top bone in the elbow. The two bones that articulate with it are the radius and the ulna. The radial head is a commonly fractured bone, and its primary function is to stabilize the elbow as a secondary stabilizer of the elbow, and it aids in rotation of the forearm. Dislocations of the elbow are a quite common injury that we see, and it's usually from a fall into an outstretched hand. This is a picture, I don't know if anyone remembers Game 3 of the NBA semifinals against the Miami Heat when Rajon Rondo dislocated his elbow, had it pop back in, and 10 minutes later was back on the court. So that's not the typical course for dislocations. The treatment is, again, usually a reduction in the emergency room, splint, and early range of motion, and we'll talk a little bit about that. Surgery is sometimes necessary, and it's usually in cases where there's an associated fracture. So let's talk about some of those fractures. Most common fracture that is associated with an elbow dislocation is the radial head fractures. The symptoms are obvious. They're usually pain, swelling, inability to move the elbow. These fractures are classified, and the treatment is based on their classification. The classification system is based on how many pieces are there and how well are they aligned. That's the bottom line. And that really guides our treatment. Ones that are well aligned and not in too many pieces can be treated with early range of motion. One of the problems with elbow fractures and dislocations is that elbows get very stiff if they're immobilized for too long. So we want to get it moving very early. Sometimes we can fix it, put a little plate on it, and put the pieces of bone together. Sometimes we can't. If we can't, we still need that radial head. It's very important to the elbow, and we need to replace it with a piece of metal, and sometimes metal and plastic. Other fractures, ulnar fractures are very, very common fracture this winter. It's typically a fall, a direct fall onto the elbow. Can also be an avulsion injury because the triceps tendon inserts on the edge of the ulna bone, called the olecranon. Non-operative treatment is sometimes indicated, although it typically requires a prolonged period of immobilization. And we just talked about how prolonged periods of immobilization of the elbow is a no-no. That causes a lot of stiffness. So low demand patients, I think that's reasonable, but for most patients who have displaced fractures, operative fixation is typically necessary, and it's usually plate and screws or wires. The last trauma that we'll talk about is humerus fractures. Fortunately, they're much more uncommon, but unfortunately, they are much more complex and usually are related to a much more higher energy of mechanism. Non-operative treatment, again, is indicated for low demand or ill patients because it requires an extended period of time of immobilization, which we know is not good. So operative fixation usually involves some form of fixation, plates and screws, and that type of thing, sometimes even elbow replacement surgery. The bad news is that 25% of patients, when looked at a year, said that they didn't have very good results, and usually that was a result of a loss of strength and loss of range of motion. And that's it. Thank you very much.
I'm Michael Brunelli. Nice to meet you all. The one thing that Lewis failed to mention about why, at least why I'm such a homer here at Milford Hospital, is that I was born here. And the guy who delivered me is still here walking around. So I always tell him what a good job he did. So I'm going to talk to you about shoulder and some of the various causes of shoulder pain and shoulder problems. These are the big things that we treat in and around the shoulder. Of course, rotator cuff tendonitis, shoulder instability, fractures, and arthritis. So rotator cuff disease is in a given day, I probably see at least 5 to 10 people with shoulder problems that typically amount to rotator cuff tendonitis. And the symptoms that the patients have are generally pain with overhead activity. This can be work, this can be related to work or sports or trauma. You can imagine a baseball player throwing the ball, pitching over and over, a football player, people at work, electricians overhead all the time, putting up fixtures, etc. Some of the symptoms that the patients have is they'll tell me that it hurts, especially at night when they sleep. They might be fast asleep, and they roll on that shoulder that's hurting, and they're awake for the night because it's aching. The other thing we see is the patient will say that when they reach back to put their coat on, that reaching back extension, or reaching behind as if to get something in the car in the seat behind them, they'll aggravate this condition very commonly. And just the picture is to show some of the anatomy where you see the clavicle on the top, the acromion, there's a bursal sac here. What you don't see on top is the deltoid, which is basically under the skin here, and the humeral head ball and socket area right here. So how do we figure out if this is what's bothering somebody? They come in and they tell me some of their symptoms, and then I examine them. We look for what's called impingement signs. During the examination, we try to mimic their pain. And we're looking for I examine their shoulder in such a way to move their arm to see if I can reproduce the same symptoms by purposefully impinging the tendon against the acromion. I'll have a diagram to show that a little bit better. You're looking for strength. Can they lift their shoulder? We isolate each of the 4 rotator cuff muscles and look to see if they can actually activate them and move the way they're supposed to. Sometimes the patient can't. I'll ask them to turn their thumb up to the sky and lift straight up this way, isolating the supraspinatus. Okay, if they can't do it, if they're doing this or they're dropping their arm as soon as I resist them, I can do an impingement test, which is an injection with pure lidocaine, and I basically numb their pain. Once their pain is gone, sometimes they lift their arm straight up. Right? But if they can't, then I'm suspicious that there's actually a torn rotator cuff. Treatment is always activity modification first to avoid doing the things that are aggravating it. Over-the-counter anti-inflammatories, physical therapy. If they're having trouble despite those initial simple treatments, we get into a discussion of imaging. We're looking at x-rays, potentially MRIs, and in cases where we can't get them better or imaging documents a severe problem, we might end up talking about surgery. So here's a picture of an x-ray finding. Whoa, breaking up the joint. Is it still working? No. If you're looking at the side view of the acromion here, underneath here is where the rotator cuff is. So if this space between the head and the acromion closes down, you're going to have increased likelihood that lifting your arm up is going to pinch the tendon against that bone. Here's a patient. This is where it should end, the normal acromion, and this patient has a big, huge bone spur. There's a ligament on the end of that bone that's calcified. If you guys, again, normal, the end of the acromion looking straight on should end here on the outlet view, but here this patient has calcified his coracoacromial ligament. So as soon as he picks up his arm, he's going to be bumping into this all the time and get those symptoms that we talked about. And so this is just an example of some of the therapy exercises. Typically we order therapy, send you to a physical therapist, but home exercise program is a big part of what you have to do. Here's an example of how we inject the shoulder. Again, this is a common procedure. I probably gave 7 or 8 steroid injections for the shoulder today. And this is the same technique if you want to do an injection test to see if they have a torn rotator cuff by anesthetizing the cuff, or you can do a steroid injection. And there's a couple approaches, but essentially what you're trying to do is to get underneath this bone, get under the acromion in the subacromial space, and you're basically treating, again, this is the acromion, and this is the subacromial space where the bursa is. You want to bathe that inflamed tissue with the anti-inflammatory. And so in the cases where either the x-rays or MRIs or the long-term treatment is so advanced that they're not getting better. Ultimately, they may be candidates for surgery, and that's what I'm showing in that diagram is arthroscopic surgery. I would say almost 100% of shoulder, not all shoulder surgery, but certainly rotator cuff disease is generally treated by arthroscopy now with very little opening or incision at this time. The techniques have become so advanced that we can repair and do most of the work around the shoulder all minimally invasive with the arthroscopy. And it's very effective. The problem, of course, if you need a rotator cuff repair, you can't move for 6 weeks. So that's annoying. And Jeff was talking about how important elbow motion is. Once we repair a rotator cuff, it's a little different. We have to let that heal before we can get aggressive with your therapy and strengthening. So the next problem that occurs around the shoulder is instability. And instability is typically a younger person's disease. Often it happens related to sports or trauma, has to do with instability of the shoulder. In younger patients, they can actually sometimes voluntarily dislocate or sublux their shoulder, or are aware that certain positions will cause instability. For instance, reaching up, playing basketball to go for the net. I've had patients come in who dislocate just doing that, reaching for something on the nightstand or to reach a light switch. These are the positions that we call positions of risk that put stress on the shoulder and can allow an unstable shoulder to dislocate. Some people have instability that they're born with because their joints and their soft tissues are so lax to begin with. In this picture, what you're seeing, this is the glenoid, which is the socket with the head removed, and the tissue around the outside is the labrum. And what you can't see here is the biceps tendon inserts in the top of the labrum, and they're trying to show a tear of the top of the labrum in that picture. But what the labrum actually does is the one design flaw we have is that the socket is too shallow. So the labrum acts it's a soft tissue component that deepens the socket and helps keep the head in place. How does that work? The head is huge, this surface is flat, and the labrum is really not that big. It's just, if you were to cut the labrum and look into it, it's a shape of a triangle. So how does that work? Well, anybody who knows anything about cars and trucks have seen this piece of black rubber called a chalk block. You can take a gigantic truck on a hill and put this tiny little chalk block underneath that big wheel, and it won't roll anywhere. And that's what the labrum is. The labrum is essentially acting like a chalk block to keep that giant head centered. So if you damage that labrum, then the head is going to pop out, based on the direction of where the labrum is injured on that sort of circumferential shape. As always, we try to get people to try to avoid any major treatment. So if we can do activity modification for their problem, we do. So for instance, if the patient says, every time I do this, it goes out. What do I tell them, cuz? Don't do that. We try to get them to do PT, okay? If things persist and progress, there's imaging. This is a slightly different imaging technique where we inject the shoulder with a dye because it helps us see that labrum better on MRI. And then you get into surgical discussions. This is often, especially in a young patient, an arthroscopic procedure, but there are cases where the unfortunate truth is if a patient comes to me with an unstable shoulder, I can tell them how they're going to do based on their age. The older they are, the better they do. The younger they are, the more likely they're going to dislocate again. I will always try to treat them arthroscopically, but if they dislocate again, especially if they're like the 20-ish-year-old person, the second procedure will be open. And it's a much more drastic procedure to keep that head centered because you don't want to keep going back and doing the same thing over and over if it failed the first time. And then, of course, there's all kinds of shoulder fractures that can be the cause of pain and discomfort, most commonly secondary trauma. It occurs in all age groups and can involve the entire shoulder girdle. We often try treatment to be non-operative, trying sling and immobilization when appropriate, but often it can be surgical. These are some examples of proximal humerus fractures, and this is really sort of the top of the humerus breaking the head off. Very commonly, we'll see fractures that break through the head. Sometimes the head can be broken into a number of parts. It can be so severe that you can't save the head. And sometimes, like Dr. Dietz showed on the elbow, he couldn't save the radial head. He had to do a prosthesis. Same thing with the humeral head. If the fracture's bad enough, you'll actually do a replacement. And here's just some pictures showing you what that might look like. If at all possible, depending especially on the age, you want to try to put a plate construct to reconstitute the shape of the head and hold it and allow that to heal. But in cases where, you know, you can say how thin this person's bone, and this is probably an older patient with his head was so badly damaged it couldn't be saved, so we have to put a prosthetic replacement in there to reconstitute the glenohumeral joint. Here's an obvious one. It's a clavicle fracture. You can see the midshaft of the clavicle, how badly displaced it is, broken here. Sometimes that will stick up so hard and so far that it actually stretches the skin. It can place the skin at risk. So you want to reduce that. Most clavicle fractures can be treated without surgery. In this day and age, the techniques have changed. So this device on top, we actually can put the plate on the front. The problem here, of course, you can imagine putting your backpack over the top of that plate, right? Rubbing right on your bone there when you're carrying. So now they've even got plates that go on the front, so you never have to go back and take the hardware out. So techniques have come so far that although we used to commonly treat clavicle fractures without surgery, we do it increasingly to get people back to activity and function sooner. Because if you put that plate in, it's so strong, you can actually start moving pretty quickly. And then the other topic I wanted to touch on briefly is arthritis around the shoulder. Again, can be due to trauma, which is we refer to as post-traumatic arthritis, or a dislocation, or an unstable child that has chronic instability his whole life can end up with arthritis and need arthritis surgery at a younger age, say in his 50s, 60s versus 70s, 80s, you know. It can be from inflammatory disease, and it can be from a rotator cuff tear. And that actually is because if you tear your rotator cuff and don't get it treated, you develop an imbalance in the motion around the shoulder, and the humeral head doesn't sit where it's supposed to sit in the socket anymore. It lifts out and it grinds itself asymmetrically, and that leads to arthritis as well. So unfortunately, this picture's not great, but you want, of course, a nice round humeral head is what I'm trying to show here. And in this picture, this head is all deformed, and I have a better picture there showing the deformity that develops. The head becomes flattened. You get calcifications and bone spurs. This one's really bad. I'm sure this person has very little motion, given that picture. And you know, the treatment for those patients, always activity modification. Can you live with this? Is there something we can do to make it so you can get along this way? If not, we talk about therapy and stretching. There's not a lot of therapy to be done for this type of arthritis. It's basically the ball in the socket is worn out. So you get into the discussion of over-the-counter anti-inflammatories and steroid injections. You know, if I go back to this picture, in order for a steroid injection to work here, you've got to put the needle in that tiny slit, that tiny space where these two things come together. And that can be difficult to do, although we do it in the office for patients. Often it's best to have that done by the radiology department, where we have them take an x-ray of your shoulder and guide a needle into the joint and give the medication while they're watching on a screen and make sure they're in the joint when it's given. Oh, what did I do? I think there it is. Hey, just kidding. All right, so, and then these are examples of the prosthesis. You saw a prosthesis for fracture. The prosthesis for arthritis is similar, except the bone quality is usually better that you have to work with, and you actually replace the socket side as well. Whereas in the fracture type, you're not replacing the socket side, and this shows you the peg going into the glenoids. This is sort of the ball in the socket. And those are some x-rays showing various joint replacement prostheses. And thank you. Look how much whiter my hair is now.
So we can take any questions. Is this on?
On the shoulder?
Yeah.
My injury started the second week of September last year.
Okay.
So it's been 7 months next
Yeah.
week. I have a torn rotator cuff in my
Okay.
left shoulder,
Yep.
a frayed one in my right shoulder.
Okay.
I've had x-rays of every bone in my body, bone scans, MRIs to find the two,
Yep.
and been to 3 or 4 specialists.
Okay.
Can't find anything. They can't help me.
I don't understand why they can't.
They don't want to operate because of my age.
you look pretty
They check
healthy to
for
me.
rheumatism,
Yeah.
arthritis.
Yeah. Yeah.
I'm his wife.
Yeah. Can you help? Can you clarify the situation? You let him speak. You let him speak that long.
That was the short version. The issue with him is that he gets pain. Most of the doctors that we've been to say
Excruciating pain.
Rotator cuff pain stops at the elbow.
Okay.
My husband has excruciating pains, hands
Okay.
and wrists.
Okay.
They
Radiating down.
radiating.
Remember the test Dr. Juris mentioned?
Yeah,
The EMG test?
yeah.
Has any of those doctors talked to you about the need for that test?
They've done X-rays
The
and
nerve test, though?
they can't in the X-rays
common
with.
They said I
problems.
do not. The last gentleman, he was what was he? Specialist.
He was a he's hand specialist also.
At woman
All
in
right.
Brigham's in Boston.
Yep.
He said you definitely don't have carpal tunnel.
Yeah, carpal tunnel.
No.
But
Yeah.
here's one of the common problems with shoulder pain.
Okay.
That I didn't stress here because it's a little confusing. Every now and then I'll see a patient who has shoulder pain, and if I do an MRI, if I do an MRI on everybody in here, on everyone's shoulder, even if you're not complaining about shoulder pain, I'm going to find something wrong or something that's not normal, right? So it doesn't mean you treat every shoulder problem. But in your case, they happen to find something in you, but the fact is that you can actually have pain. Shoulder pain can mimic cervical spine pain, and cervical spine pain can mimic shoulder pain. So in a case where someone has bad shoulder pain, if, as Dr. Juris said with the carpal tunnel, if it's not adding up, if it doesn't exactly look like it's a carpal tunnel situation, you don't want to try to do carpal tunnel surgery because they're not going to get better. In your case, it sounds like someone should be considering, is this a neck problem, right? Before they decide to operate on your shoulder because the MRI shows a tear,
If I may, I say excruciating pain. I just got over excruciating pain. I had a cortisone shot in each shoulder.
Yeah.
Mid-December.
Yeah.
24 hours. Like new. I mean,
Okay.
I was in pain.
That
Bent
helped?
over all night. Pardon?
Did the injections help? Is that what you're saying?
Yes, they did. 24
Well, then
hours.
that goes towards it
All
being
right,
a
but then
rotator cuff.
a month later,
Yeah.
it lasted about a month.
Okay.
I went back to the same orthopedic surgeon
Yeah.
and said, do it again, will you?
Yeah.
She said, I'd rather not, can't, because it hasn't been long enough. I don't
Yeah.
want to. She did, and it took 4 or 5 days. The pain was less, but it didn't completely go away.
Well, that gets to the point that I made when I talked about using a cortisone injection for diagnostic purposes in the carpal tunnel, for example, is that response to an injection in the shoulder, getting rid of your excruciating pain going down on the hand certainly suggests the shoulder's the problem. And that's where it should be looked. And it can be thought of in that sense, or in your sense, as a diagnostic tool that demonstrated where at least a good portion of your symptoms are coming from.
And they come
So
and go.
there's no way to diagnose you standing 15 feet apart talking with you or know what to
I
do.
understand.
But certainly
But we're
for
close.
whomever you do see or go see, the fact that the cortisone injection into the shoulder provided really good pain relief is a very important point to emphasize.
Hi, I have two comments and a concern. I'm out in the Framingham way. Whenever I see acquaintances and stuff and they have casts or some problem to go on, I said, have you talked to Dr. Juris? And they're like, no, seen the two other guys. And it's so nice to see a face with you guys because I thought it was just like a phantom doctors to make Dr. Juris's office seem
They're
bigger.
neither phantom nor fantasy.
But I think I might have spoken to Dr. Juris before. He's operated on me twice. The carpal tunnel thing, I don't think it's that, but I do landscape horticulture work, and in the spring, in between like raking and holding an edger and pruning, I get that where I wake up from my elbows down to my fingers just burning. I call them like just dead carrots. And I literally have to get out of bed and put my arms down to get some relief because it's just excruciating. It might just be because of my age now and the work I've done for so many years.
Did you have your carpal tunnel released before?
No, Dr. Juris said it wasn't necessary. Maybe I should see one of you guys.
Sounds like it's getting necessary.
But I'll go see him again.
Certainly there are things you do.
Yeah.
Just for example, we've all been doing a whole lot of nothing for the last 4 or 5 months. So Well, shovel snow. You're right, guy. You're right. But in terms of going out and doing all sorts of things, yard work and gardening is tremendous for causing not only aggravating carpal tunnel syndrome, but causing the elbow tendonitis that can be sore at the elbow and can also radiate down to the hand and mimic some of those other symptoms. But
Yeah, he's over the years he's done a ulnar release on my right elbow
Yeah.
and trigger finger on my left hand, and
those got better.
Yeah, but I've seen Dr. Juris because I've had to have other surgeries on my feet and stuff at the hospital, and he probably must get sick of me bringing this up every time. I don't know if he knows where I'm going to go with this, but even if it's outpatient surgery, I get a little, you get nervous and stuff, you know. And so I was going in there, and some music's being piped through there. I don't know, and I said something like, he could have just said, let's get him out of here quick. I got another patient. And what I said was, I don't know what music was on, but I just said, you don't have any U2? Because I like the rock group U2. So he says, you want U2? And he had it on his iPod and piped it through. And then I went out to that. And that to me just showed a really, caring doctor. And I always bust his chops about that.
If he had asked for disco, I wouldn't have obliged.
Trigger finger, and how do you treat it?
Do it? Yep. Well, I have one right now, and what a trigger finger, it's the same kind of concept where the tunnel that the tendon travels through gets thick and tight. And often it's worse at night, and again at night we'll sleep like this. So often with a trigger finger, you'll wake up in the morning and the finger is stuck down. And then after you loosen it up a little bit, it's okay for the rest of the day.
It gets better during the day, but...
And when it's painful when you push, you'll notice that it's sore, not where it seems like the joint is catching, but right down here in the palm, because that's where the tendon's getting stuck. So it's actually, the tendon isn't fitting in the tunnel, and that's why we'll often treat that with a cortisone injection. That is one of the more painful cortisone injections, unlike the carpal tunnel. But that will cure the majority, a good 60-70% of trigger fingers will be cured with a cortisone injection.
So it would be a cortisone.
Right, and the ones where it recurs or recurs after a second injection, the surgery for it is a real quick, simple thing, no splint afterwards. Move the finger right away, use it right away, basically.
Okay, thank you.
But that's what that is. You had your hand up. Oh, we got to get the microphone so we can record for posterity, sorry.
Nobody spoke to Dupuytren's contracture? And have you had to do multiple surgeries? Actually, Nail Buff did my first, but I had to have it done again.
Maybe I was scrubbed on that case.
I had it done a second time to heal it, and then I had a third surgery on this hand, and it needs to be redone. I think it was a resident that did it. Anyway, I had no success, and I have more that needs to be covered. So who does Dupuytren's, and have you had to do it more than once to completely heal it?
We all do Dupuytren's. That probably did not have anything to do with who did the surgery. Recurrence rates for Dupuytren's are very, very high. It doesn't have anything to do with technique. It just has to do with the nature of the disease. So my mother-in-law has been operated on 4 times. Unfortunately, I never got to put a knife in her, but I've been dying. I'm trying, but no. So oh, sorry. Check that. No, but it's very, very common to need revision surgery.
Does anybody do the shots?
Well, the thing to understand about Dupuytren's disease is you have the biochemical predisposition to form that disease. It's not like it's a tumor that you take out and it's gone. Your body has the propensity to form it. So we know that if we take it out, it's got a 50% chance of recurring there or somewhere else on that hand or the other hand. And that's just the way it is. You asked about the enzyme, Mike. Do you want to?
I'm sorry, I just want to comment real quickly. Did you start to ask about the enzyme?
I did.
There is an injectable treatment for Dupuytren's since 2010. We did not immediately start using it because we didn't want to charge the patients. If the patients who got the injections initially were paying $3,000 plus out of pocket, and we didn't want to do that to people because there's a chance that it wouldn't work or have an early recurrence, and then that poor patient's out $3,000. But once the insurance started to cover it and pay for it, we've started to do it, and we've had some good success. I've had patients who had surgery on one hand, and it's a lot to go through that surgery. As you know, there's a lot of rehab, the night splinting, and then all the pain and swelling that goes with that. I've had patients come in and say, okay, you did this hand, this is good, I need you to do this hand. And during that period of time, the injectable had become available, and I said, let me do an injection for you. and she got an injection and got an excellent correction and couldn't say enough about the difference, about how nice it was to be able to do an injection. Not every case of Dupuytren's can have an injection. It's a very specific exam that we look at can make that decision that the injection is appropriate, but when it is appropriate, you can avoid a surgery.
Can you do an injection on something that's already been operated on?
Not so often because the cords are not so prominent then. You need a prominent cord.
I was going to ask about that
Yeah.
particular thing. I don't know how to pronounce the
Yeah.
word, but
Yeah.
I have that too.
Yeah.
And the material that I've read up on it
Yeah.
says that you don't know how it's caused.
Yeah.
And I think it's caused from a lot of heavy work,
Yeah.
which is what I was doing
Yeah.
prior to mine coming out. I was doing a lot of yard work.
It's caused more by genetics than anything else, and it's just very common that people of an England, Ireland, Scotland, Northern European background. That happens to be a good portion of those of us who live around here, but it's more related to that than what you do.
As far as
That's interesting. I didn't read up.
the last time I checked, the FDA had not approved it for, if you've already had an operation, it's not approved for revision surgery, so an injection after surgery.
I've never had any
Unless that's
really had
recently
any
changed.
problem with it. It doesn't hurt or it doesn't interfere with anything. It's just when I wake up in the morning, my fingers are all, I unblock them. And I was just wondering, is it going to get worse? Or
Yes.
can, or-
Generally slowly progressive.
No, all right.
Not always, but it's certainly potentially low-level trauma can aggravate the little tissue, the myofibroblasts, and make it worse. So if you are traumatizing it, stop that.
Trying to stretch it is counterproductive.
Yes. Yes.
Yeah,
Yep.
I know what I can't.
Yeah.
There you go.
Okay, you had a question?
Dr. Jurist, at the beginning of the year, I started experiencing what you described as the carpal tunnel, where your fingers are numb, but the pinky is not. And I was at the Worcester Medical Center today. They were going to do an injection on my neck. They saw a pinched nerve on the C5. I had had an MRI a couple of weeks ago, but he decided not to do that based on an examination of my symptoms. One of the things that I read about over the last couple of weeks was how ciprofloxacin and those classes of drugs can affect the nerve system. Do you have anything to tell us about?
I think you got to be careful about what you read.
Yeah,
and
well, it
look
was an
up on the
FDA
internet.
release. That's
right, but those are still the rare occurrences, or what we
Okay.
call zebras
All
instead of horses, for example, and that you have to go back to the basics most of the time. And just because an MRI or an X-ray shows what they might call a pinched nerve or a bone spur, that doesn't mean that's what's causing your problem. That's where you have to correlate the exam and the symptoms with what you have and what makes sense.
Yeah, they're going to start the EMG
because the
on me.
majority of people are going to have bone spurs on their neck on X-rays. Majority of people over the age of 30 or 40, which is most of us, I think, are going to have abnormalities on the MRI suggesting pinched nerve, and it has to be correlated with what's actually bothering you. And that's where doing the exam and having the experience of treating these over a number of years or decade makes a big difference. Because you can find a test to justify almost any operation, but if you don't really correlate it with what's wrong with you and what the exam shows, you're doing a lot of unnecessary and unsuccessful surgery, which is something that we just hate to do.
Right. Well, they did the MRI, and they saw this bump on C5 and said that's possible that's what it is. I am going to go be doing the EMG.
Forget we said how painful it is.
Oh, I know. I had it on my leg, and it was unbelievable. And so I am going to proceed with all of that. But after reading what I read about ciprofloxacin and how it can cause all these symptoms, which they described, that this, it feels like you got a mitt. In the morning, I couldn't close my hand. I'd go to open my hand, and when I'd get one finger, it would flick open. Very, very painful. But you don't think that the ciprofloxacin and those types of antibiotics have any effects?
Not in the,
That would
in the
be
huge
not
volume.
Well, would it
like what you're
exasperate the-
describing.
would it-
You never can say never with anything in medicine, but it's extraordinarily unlikely that that's the root of your problem.
Not the root, but could it exasperate it? Could it make it?
We can't give medical advice.
Oh, I
like
understand.
That. Yeah.
It's much more likely that you have a pinched nerve in your neck or have carpal tunnel than it is to have an effect from ciprofloxacin.
Right. That's the majority of patients that we see.
I think that brings up another point. Not every numb hand is carpal tunnel or cubital tunnel. So, you know, so there are other conditions that cause that.
Neuropathy, as you said.
Oh, I have a question. When you were talking about activity modification as a treatment, does that mean I can never do this, or does that mean if I stop doing that for 6 months, then it'll get better, and then I can do that?
So what I always tell the patients is that if you do activity modifications, you know, basically I tell them, if I put you in a glass bubble, right, or bubble wrap, you'll be fine.
If I don't move at all, I'll have no pain.
Exactly, but that's just not reasonable. Right? I tell some young mother with, say, tennis elbow, okay, you need to stop doing this, you need to stop doing that, and she just points behind her on the exam table. There's like 4 of her kids. She's like, I'm not stopping anything. You know? So the answer is you do have to use it with sort of your judgment in that, you know, what is it? What I tell patients is think about what you're doing. What is the thing that causes it? Is it basketball? If you say, our goal is to keep you functioning. So if you say to me, I play basketball.
I'm like, a skier. And I water ski and it pulls.
Oh yeah, right. So let's say you say to me, Doc, there's no chance that I'm going to avoid the skiing that's causing my pain. Well, then we move down the algorithm, right? You're somebody who needs a high level of functioning. You're, you know, an athlete. You're active. And that's our goal. Now, if maybe you're somebody who say, well, I water ski once a year and then I have pain for, you know, 6 months afterwards. Obviously, that person can give up the water skiing. So the answer is, if you can make adjustments in your daily routine or in your activities that allow you to accommodate, then we want you to do that. But if you can't, we're more than ready to move on and figure out, like, maybe you've got a bone spur that needs to be taken out, and then you're going to be the best water skier there ever was.
I'd love it.
Sure.
So you had said, I'm sorry, I don't remember your name.
Dr. Dietz.
You had said with tennis elbow that it may take a couple years and the symptoms may go away.
Mm-hmm.
So is this if you stop doing that activity that you love to do?
Well, the study that was quoted up there, they looked at a very large subset of patients, and they did not restrict those patients. So the short answer to your question is no. There's no indication that activity has any effect on that. So I would recommend, you know, within reason, like Dr. Brunelli said, you know, I mean, you have to, you know, if you have tennis elbow after one episode of water skiing, but you don't really like water skiing, then yeah, you should restrict that activity. But I typically don't tell patients to restrict activities that they have to or need to do.
What if you've already had it for a year or so?
So that was the average. But I will tell you that I've had patients that have had tennis elbow for 4 and 5 years. And so, you know, that study was stopped at 1 year. And I will tell you that, yes, it's very common for those patients. And you may be one of those patients where we said, bottom line is, most patients, it goes away, but not every patient. Mm-hmm. So you may be in that category of a patient that needs more advanced treatment.
Okay, thank you.
Mm-hmm.
Mine's a little different. It's gone on for over a year. It's in this area here. I started with my regular doctor. They did an x-ray, and it showed a combination of tendinitis, bursitis, and arthritis. So they sent me to...
Trifecta.
Yeah, I got the whole thing right there. So they sent me for physical therapy. I did that for 12 sessions. Didn't get much relief, had a lot of pain during the therapy. They then gave me a cortisone shot, and that gave me some relief for about 2 weeks. Sent me back to physical therapy for another 12 sessions, then sent me to a specialist, and they did an MRI, and it showed what the x-ray showed, the same 3 conditions. They did not feel it was a rotator cuff tear. They didn't see anything like that. So they then sent me to a specialist who extracted calcium from the tendon in here, just a needle extraction. And that gave me some relief. I went back, I can't remember if it was 2 or 3 weeks later, because he thought there would be more to remove, but there wasn't. So that was, I don't even know, months ago now anyway. probably in the summer into the fall. Around January, I decided, well, I have some pain, but I was doing the exercises the physical therapist had given me at home, and I decided to go back to the gym where I was doing Zumba, yoga, and a little Tai Chi, senior level. The pain is worse than ever. I can go up, I can go out, I can go back. I cannot go across. Some days I need a lot of Advil, some days I don't need much at all, but I don't know whether I'm doing more harm than good by exercising.
So some of the things that you do when you're causing pain is you are doing harm. So the example of the impingement patient, right? If your hand is up over your head and you're putting in light fixtures over and over, you're impinging. So you're rubbing that tendon. And initially the patient may have tendonitis, which is simple inflammation. Over time, the tendon becomes degenerative. We refer to that as tendinosis. If that person keeps doing, because they have to, they own the business, they're in charge or whatever it is, and they just keep going, eventually they're going to tear their tendon, okay? So, we have that old adage, no pain, no gain. Well, that type of pain is not no pain, no gain. That's actually causing you harm in some cases. Again, I have a sense that you're probably describing an impingement type of phenomenon when you're reaching across the body and causing pain, but there are other things that it can be. If you have full range of motion, as you've suggested, I would knock arthritis down on the list as the problem, and it sounds like you're talking about a calcific tendonitis, which is slightly different and very painful, very painful.
Yeah, so maybe I have more calcium in the tendon.
Yeah, exactly.
Go back for another extraction, at least for the first step.
Yeah.
And what about it? Just don't do the stretching exercises and whatever,
well, if you're impinging, I think somebody needs to look at you and decide, are you a patient that might need to have the bone reshaped to make room, because the calcium gets built into the tendon, because guess why? It's impinging and it's distressed, and your body distributes calcium to that distressed area that's degenerative. Okay. So maybe in some of those patients you can actually go in and remove the bone spur, make room for the tendon, and even with the scope actually extract the calcium.
Well, he did extract some calcium, but he
but
also
blindly. He's doing it blindly.
No, he did it with a sonogram. He had it on a screen and then followed in with he did say there was a small spur, but he didn't feel at that point it needed attention.
Sure.
Now I guess it needs attention.
Well, potentially, sure.
All right. Thank you very much.
Sure. Hi.
Does using the computer really aggravate the rotor cuff?
It really shouldn't, unless there's something about your positioning. Right, I thought you were going to ask me, does it cause carpal tunnel?
Right.
Got the brace on.
I was like, Dr. J's all over that.
The fact, what happens is that using the computer, right, as we said, it doesn't really cause carpal tunnel syndrome, but if it's, what Dr. Brunelli was talking about, if it's positioned wrong, and the most common problem is the keyboard's positioned too high. And so then you have to reach up, and that causes a lot of elbow and forearm tendonitis and pain like that. That can cause it to be very uncomfortable, particularly with your mouse hand. If you have to reach up and over and hold your hand up to use your mouse, that can cause tennis elbow in no time flat. So the position and the setup is very important.
Okay. The second part of that is, if I was diagnosed and I was with the rotor cuff, and I don't go to therapy, is that ever going to get better?
It can get better if you, again, avoid doing things that make it hurt. It can also get worse, and then lead to various conditions of arthritis. If you're able to do your activities and not cause the rotator cuff pain, and the functional loss that you have from having the condition is not terrible, I suggest PT, but it's a big deal. You getting out of the house, going to therapy a couple times a week, a lot of co-pays, a lot of, and then sometimes the patients aren't happy to get small improvement, and it's a lot of effort on their part. So I try to tailor a treatment to the person if I can.
The thing to remember is, what Dr. Brunelli is saying, how much is it bothering you, how much is it affecting your activities? Because the fact of the matter is, for rotator cuff tendonitis and these problems, it's almost ubiquitous once you get over a certain age. And interestingly, a friend of mine in town was entertaining some visiting orthopedic surgeons from Korea. So in Korea, they call it 40-year-old shoulder. Just indicating they expect most of us over the age of 40 are going to have some element of that at some point in time. I do. And certainly it just depends how much it's affecting your activities in your life in terms of how aggressive you are about taking care of it.
Hi, I just have a quick question. I have a younger daughter, and actually we saw Dr. Brunelli a month or so ago. She had some weird thing with her fingers going on, but she actually has arthritis in her fingers, and we see somebody for it, and she does take medications for it. But she was home this past weekend for Easter, and I never really noticed, but her knuckles are getting large, and her fingers are starting to look a little oddly shaped. She's away at college. Is that something that
you said, I'm sorry, did you say she has the diagnosis
Yes.
of rheumatoid? Well, as Dr. Juris showed you, that some of the deformity that the patients with rheumatoid can get.
She's 18,
juvenile-
but how does it, how do you repair things like that?
Does she have a
or-
rheumatologist?
We do. We just got diagnosed and started seeing one.
Because the point of when I was showing those awfully deformed rheumatoid arthritis hands, what I was saying is that's for most of the time now a thing of the past, fortunately, because there are so many good medications that they actually call disease-altering drugs or disease-altering medications, because they, instead of just treating the symptoms, they actually stop the progression of the deformity and alter the course of the disease. So she should really be seeing a rheumatologist pretty quickly and seeing in terms of whether there's some medications that can help her with that.
Change the path that she's on.
Right. We've switched up quite a few different times with some different medications because she's not getting a lot of relief.
And you
so
can
we're
get
still
rheumatoid arthritis in the younger patients. It's referred to as juvenile rheumatoid arthritis. So it is possible.
Yeah.
Right. You want the treatment of that to be medical to prevent it rather than surgical once it occurs.
When we have to get involved. Right. Exactly. Anybody else?
Here, take mine.
For seniors still doing strength training, can you offer me and the rest of us any guidance on how not to hurt ourselves?
How does this senior do it?
Once I stop. Basically, it's very important to continue with exercise, not just cardiovascular exercise. The kind of limited weight training or repetitive activities is good not just for strength and make you feel good. It's good for bone density, particularly in women in terms of osteoporosis. And the idea is you don't want to use maximum weight. In general, you might want to use lesser weight, more repetitions to try not to put too much strain or stress on the muscles and tendons, but still get most of the beneficial effect. To the extent that you can do stretching and maintain flexibility, something I'm a total failure at, but is very important also, and core strengthening.
So do lower weights but more reps.
Yeah.
Yeah.
You talked about the other side of the hand that's not carpal tunnel. Down the left side.
The ulnar nerve.
Down the little finger where you get numbness or tingling. You said that was something to do with the...
That's the ulnar nerve at the
elbow, but you didn't really go into that a whole lot.
So that's called cubital tunnel syndrome. That is a pinched ulnar nerve. There are 3 nerves in your upper extremity. One of them is the median nerve. That's the nerve that's involved in carpal tunnel. The nerve that's involved in causing numbness and tingling in your ring, or sorry, got double microphone. The ring and small finger numbness is the ulnar nerve. It's called cubital tunnel syndrome.
What do you do to correct it?
It depends upon your symptoms. So if your symptoms are intermittent and they only occur while you drive or maybe while you're at the computer, then you want to avoid prolonged periods of elbow flexion. So oftentimes patients will say, when I'm driving in my car and my elbow's up on the console, my hand goes numb, or when I'm talking on my phone, my hand goes numb, but I put my elbow down and it goes away. Those positions of elbow flexion can cause more pressure on the nerve and then can cause the symptoms. If the symptoms do not go away with simple things, oftentimes I'll recommend that you get that nerve test to see if there's any nerve damage that you may need a release.
And the other point with that nerve is it is usually compressed or irritated at the elbow, but it can also be irritated at the wrist. And that's part of where the exam comes in. I had a patient last week I operated on who actually had a small mass of ganglion pushing on the nerve here, that ulnar nerve at the wrist and in the hand. And so part of that is where the exam and seeing exactly where the numbness is, what muscles are involved, and then what the nerve test shows can help localize it a little bit better.
Are you the elbow guy?
But
all the
Dr.
elbow guys.
Dr. Brunelli and I both do elbows.
If you released a tendon in my elbow, would it look like this after?
Hopefully. So we try. We try. Was that tennis elbow surgery or?
Yes.
So we do give
work?
a lot of. Yeah, that's probably the more important thing. Did it work?
Well, it did work.
Yeah.
But we try to be thoughtful about the size of
So
our
that's a
incisions
little
and the
choppy,
cosmesis.
big.
Yeah, that's
Some
probably-
people scar differently than
Yeah.
others, though. So I can't
I think
really.
most of us would do that through a slightly shorter incision.
Yeah.
The bottom
Yeah,
line is,
yeah.
if you needed that surgery, your elbow hurt really bad, didn't it?
It did.
Yeah. And if it's better, you're probably thankful that it's better. I don't mean to say that the scar doesn't make a difference. It's very important, but.
I am, but when you read that the doctor who operated on you doesn't practice anymore for bad reasons, it makes it a little bit. Anyone want to take a
No
guess?
comment.
Well, then I'm glad your elbow doesn't hurt.
It wasn't any of you guys.
Good.
No, because we
Thank
still
you.
practice.
Yeah.
That's true. Do you want to ask a question about the inside of your elbow? Chicken.
Any other questions? No, you know what? I've
Prolotherapy.
Prolotherapy.
Are you talking about the platelet-rich
PRP.
plasma? Yeah.
Yeah.
So
PRP, yeah.
we don't. It's very expensive.
It's not covered.
It's not covered by insurance because
we generally won't do it if it's not covered because we're not going to take money from you. Yeah.
And the reason why it's not covered is because there's no real tests that show that it works.
There's no
No
literature
study.
to prove it.
There's nothing scientifically shown that it's better than doing nothing.
But actually, I will speak to it for 1 second. And the thing I do tell patients is that what that's designed to do, years ago, there was a study where they drew blood out of a patient and they injected the blood on their tennis elbow. And it was just I don't know how they even thought of doing that, but they found that it got a number of people better. Out of that study, what I changed about my treatment, and a lot of doctors have changed the way they do, is that I've learned that although I give a steroid injection when I treat tennis elbow, I don't have to put steroid in it. I could give you a blank needle. Or what I often can do, if someone has had too many injections, I'll give them a needle with lidocaine. What am I trying to do? I'm trying to create bleeding. That's what that study tells me. If you put blood where the problem is, maybe I can stimulate healing, because by the time you show up to us, your body has given up healing the tennis elbow. We're going to try to stimulate it to heal. So I use that technique of moving the needle. I say I'm going to do it like a sewing machine needle. So what the platelet-rich plasma does, they studied that situation further, and they said, well, they take your blood, they spin it in a centrifuge, and they separate out the top layer, which is clearer. It's like plasma, and it has a lot of platelets in it, and the little factors, the little chemical factors in that fluid are what stimulates healing. So they think it's more concentrated. But again, the studies are not so conclusive, and I find even just doing this is very helpful when I give the injection.
Would you do that even if you've already had like the cortisone and all that?
Well, it depends how many you've had. Two? I will give a person, if a person comes to me and they're asking for surgery because they've had 2 injections, I often will give them a third because I want to see their response to my technique and explain what I've said to you. But certainly, if patient says, I'm afraid of steroid, I get into the discussion about doing it with just straight lidocaine, so it's not painful.
There are people that are doing that, though. It's not to say that just because the literature hasn't supported that it doesn't work. There are things that work that aren't supported in the literature, and there are people that do that.
Like steroid injections.
Exactly.
We're not so comfortable having you be a guinea pig, so we're waiting until it's proven, and then we adopt. So, yeah. Pass that out.
She's going to bring the microphone to you.
On Dupuytren's, is there anything you can do to mitigate progression of it?
Not really. I mean, as I said, if you try and stretch it and push on it and traumatize the tissue, you might stimulate it to contract a little more. It's a strange disease. You can sit and have the nodule and the band in your palm for 20 years. And then all of a sudden it might start pulling down. What caused it to pull down? We're not really sure about that. You're going to get it or not. It's going to do what it's going to do. We don't take out those bands or cords prophylactically because in some patients they're never going to be a problem. And because of the high rate of recurrence, we wait till it starts causing the flexion contracture to deal with it or treat it.
And at what point do you surgery? What point of deflection?
So the surgery is indicated when you have a functional deficit to your hand, and we use something called a tabletop test. When you no longer can put your hand flat on the table, it indicates that there's probably a functional deficit. So that's a simple way to generally get an idea whether you may be a candidate for surgery.
In general, if it's been stable for a while and starts coming down, it's going to keep going. And you're better off taking care of it when it's a little bit flexed instead of waiting till it's a lot flexed. Because when you get it a little earlier, it is easier to do the surgery, it is easier to do the rehabilitation, and it's easier to get a better result from.
Thank you.
You're welcome.
Anybody else?
Thank you so much to the surgeons here. All of them came, which is, again, a shock for us. So we're very thankful to have these exceptional surgeons with us today.
Thank you.
Thank you all for coming and listening to us.